Good morning. It's a great pleasure to receive today a true leader in the field of head and neck oncology and radiation oncology, Dr. Paul Harari from the University of Wisconsin. Dr. Harari is the chair of the Department of Radiation Oncology at UW, Carbone Cancer Center, and is the director of the Head and Neck Cancer Spore at the University of Wisconsin, which is one of the two only funded spores currently in head and neck cancer. We hope that the number of funded spores basically increase with time. Dr. Harari did his undergraduate time at Tufts University. Then he graduated from medical school at the University of Virginia, subsequently completed his training at the University of Arizona in Tucson, and then has been at the University of Wisconsin since that time, where since 2007 has been the Jack Fowler endowed professor in cancer research, and as indicated, has been the chairman of the department. But beyond all of this, and more importantly, I think Paul's influence on the field of head and neck cancer has been the major thing to notice over the last many years. In addition to the influence on many of the trainees and the residents who rotated with him and now became basically true leaders as well in their own merit in radiation oncology. So Paul has numerous publications, more than 200 peer-reviewed publications, more than 300 abstracts, numerous book chapters. He's the chair of the Astro Educational Committee, and I could go on and on and on, but I don't think that's what we're here today. We want to basically hear his talk and views on head and neck cancer, and we are greatly happy that you're here, Paul, and extend to you another welcome to Atlanta as well.
Thank you very much, Nabil, and thank you to everyone for the warm welcome. We had a very nice dinner last night with several of the head and neck cancer team members, and it's a pleasure to be here at Emory. So I will charge right in. I'd like to make some comments about the bringing together of biology and technology. This is certainly happening across oncology, but we're seeing it very powerfully in radiation oncology. When you think about what radiation oncologists need to do, it's really not that, it shouldn't be that difficult. We want to see the tumor, treat the tumor. How hard can this be? Well, let's give a very brief peek at history. It's only 120 years ago that X-rays were first identified. Here's the image of physicist Wilhelm Roentgen with the first known X-ray image of his wife's hand. You can see how that X-ray has, talent has evolved over 100 years to the image on the right. But equally impressive is the fact that for those of you who like to publish papers, look at this turnaround. Within a week of submitting that thing, they had that published. It's really an incredible element. After the discovery of X-rays, within a decade was the first known use of X-rays for therapeutic intent, here with Georges Chicoteau treating a woman with breast cancer. And this is unveiling the field of radiation oncology essentially 100 to 110 years ago. But it is only 40 years ago or 45 years ago that cross-sectional imaging became available. Imagine what it must have been like prior to CT scan technology. This emerged really in the early 1970s. Prior to that, think of using radiation to treat a complex brain tumor based on a plain film. It's essentially what was available at that time. Think of the complex thoracic and abdominal pelvic tumors that we treat today with conformal radiation. And again, imagine the technique with ultrasound or plain films to try to delineate those treatment volumes. It's really almost hard to imagine. Flash forward 100 years to where we are today, and the use of highly conformal radiation with beautiful imaging to delineate within millimeters, submillimeters, the location of tumors and our ability to sculpt and shape and deliver with low collateral damage to normal tissues has advanced dramatically over this period of time. I want to brag about, among many physicists, one of the physicists at my own institution, Rock Mackey, who is one of many genius developers of equipment, and Rock in the 1990s conceived of marrying a linear accelerator for the delivery of radiation with a CT scanner. And up until that time, it was thought that you couldn't combine those two types of equipment because they would interfere with one another. But Rock is a fairly stubborn and very brilliant physicist, and he created the methodology where you could house a CT scanner and a linear accelerator in the same unit. And now this is commonplace. There are over 500 tomotherapy units around the world, and it gave birth to image guidance, because then now you have a full CT scanner right there in the room to be able to take rapid images of position of the patient. And so these last 20 years have really seen a jettisoning forward of technology, of imaging and radiation delivery for tremendous increase in precision and quality assurance. And these types of cartoons and illustrations are now commonplace, where the conformality of tumor targeting, if you want to just treat the scalp and not treat the brain, if you need to treat conformally one breast and not the heart or the other breast, you can treat the pleura of the lung, you can treat the bone marrow without treating the lungs and heart. It's really fascinating, and these were not possible even to conceive of 20 years ago, and now these are essentially commonplace. Here is a look at a prostate cancer plan. We're using Tomotherapy, where the conformality of the high dose is very tight around the prostate, but there is a little bit of the low dose 20 grade isodose cloud that goes further as we take Tomotherapy, and then we look at current Proton state-of-the-art, or at least used to be state-of-the-art, with static fields where you're diminishing the low-dose scatter and have very high conformality. And now the rotational intensity modulated proton therapy dose, we can see again this quantum leap to be able to essentially remove the low-dose radiation profile and just deliver dose to the target with high precision. And I know proton therapy is about to come here to Emory in the very near future. But that's not all that's happening in technology. The particle therapy goes beyond proton, and there are centers around the world that have developed various ion beam profiles that bring new properties and new capacities using various isotopes, carbon, helium, and others. This Heidelberg Ion Beam Center, Therapy Center, is essentially a whole township. It's amazing the size of some of these early ion centers for the delivery of high precision radiation. But what I'd like to do is, after this brief tour of technology advance, and I'll say a few more words there, I'd like to apply it to real-life head and neck cancer vignettes to bring to life the power of the technology to improve outcome. And so we'll make a few comments using head and neck cancer as the backdrop. Certainly the term personalized cancer therapy or precision medicine has been in vogue now for virtually a decade, and it generally implies the use of new molecular therapies that are targeted for abnormalities that are specific to tumor cells or tumor targets. But there is certainly a personalization of cancer therapy with surgery and with radiation. All you have to do is think of a loved one needing an operation, and why do you want a very specific surgeon to do that operation because you know of the talent and the experience of that individual. And there is an art to the delivery of a high-quality operation, certainly in cancer care. Very similar in radiation, where the delineation of the target, the sparing of normal tissues, the number of opportunities that we have to conform the dose but limit normal tissue requires experience and thought and artistic talent on the part of the radiation oncologist. So for many years, I think we have been personalizing these physical therapy approaches depending on factors such as patient age, performance status, their desires for outcome. These are two head and neck cancer patients that have some obvious differences, but they share one thing in common. They both have terminal metastatic head and neck cancer that cannot be cured, and they have very different objectives. The patient on the left will try any new therapy, any phase 1 trial that might have a small chance for benefit, he is ready to explore. This fellow on the right wants only one thing, and he wants improved pain control. And so the objectives are very different. It's very easy to give better pain control to this fellow and let the chips fall where they may. The bigger challenge is to try to identify agents that will help this patient. This is someone with a metastatic adenoid cystic carcinoma tumor for which we have struggled historically to find systemic therapies that have a meaningful impact. For the small head and neck tumors, here's a patient of mine with a small T1 vocal cord cancer, cure rates in excess of 90%. Either radiation or surgery are very effective therapies. You can laser excise under careful conditions this tumor. You can use small field radiation, and the outcome is going to be quite good. Unfortunately, most of the head and neck tumors are larger. They're bigger tumors with spread potential to the lymph nodes. And when you think again back to what has happened over the last 20 to 30 years, this was the state of the art when I arrived as a junior faculty member at the University of Wisconsin in late 1990, where head and neck patients were treated with this type of a setup, where we would use purple Carfusion pens to delineate the field on the skin. This, believe it or not, is supposed to be an X demarcating, the bullseye, the middle of the field. We were junctioning a lateral field that went through and through the patient right to left with an anterior beam, and somewhere here there's another X supposedly to delineate where the junction of the lateral and the anterior fields. It doesn't take too much imagination to know that this was going to be hard to set up with sub-millimeter precision day to day for 7 weeks. A lot has happened over these last 20 years in terms of treatment precision. This is that shrinking field technique that I was just describing, where a large field is initiated, and that once spinal cord tolerance is reached, the field is reduced away from the spinal cord, and we're carrying the known tumor and lymph nodes to higher dose, often supplementing dose here with electron beam that won't penetrate to the level of the spinal cord. And that shrinking field technique was used for several decades. In fact, in parts of the world is still used today, where through and through radiation, through both parotid glands, through the mandible, through all the normal tissues, and then a big, broad supraclavicular field that finishes treating the lower nodes, and that field exits right through the thoracic spine and adjacent to the scapula. So a lot of normal tissues are treated with this technique, but it was very effective. We certainly used this throughout the early part of my career, but this has evolved with the advent of intensity modulated radiation. So all of the trainees are now, in fact, only learning this. I'll bet are there a number of residents in the audience? Have you folks had experience with shrinking field technique? Okay, so that's foreign terrain now for trainees, and that's probably good. I mean, there's a little nostalgia, I think, for some of us thinking, gee, if you had to do this, could you? But I suppose why? You've got IMRT on virtually every machine. But yeah, that is a relic of history. Now our trainees are denoting tumor volumes and areas at risk, and we're sparing, at least in this case, one major salivary gland, limiting dose to the spinal cord, reducing dose to the larynx or the brain stem. And so this has become very routine. And so this three-dimensional intensity modulated radiation has afforded terrific opportunity to reduce normal tissue exposure. But there are other aspects of the history of radiation and the precision of techniques that are still applicable over many years. And I want to just show a brief example of one in brachytherapy. Brachytherapy is the local delivery of radiation seeds or implantation into tumors. It's very common, certainly, and I'm sure the trainees are familiar with it in gynecologic tumors and breast cancer, prostate cancer. There's still some head and neck cancer sites where it's quite valuable. This is a patient of mine with a lower lip cancer. His tumor extends from about here to here. It's the majority of the lower lip, about 4.5 centimeters. He's an elderly fellow, very nice gentleman, and you can imagine, although this can be removed with surgery, this is a technical challenge for the surgeon, not so much the extirpation, but the functional and cosmetic reconstruction, and to yield an outcome that is ideal when, with this type of a shape of tumor, it's very amenable to interstitial brachytherapy. And so we treated this patient in the outpatient setting with simply slipping plastic catheters right through the tumor. This one goes right through and through the tumor. This one is placed because there's a little dipping of the tumor here, and I wanted to make sure to capture that part of the tumor with a few doses here. We can use high dose rate brachytherapy technique for this treatment, where the radioactive source is brought in through these catheters. It dwells for a few seconds in each position after detailed treatment planning to provide the distribution of dose that is required. A single treatment takes about 2 minutes. The patient is an outpatient. He goes off for 6 hours, comes later in the day. Over a course of 1 to 2 weeks, this treatment is complete. This is this patient of mine from a photograph just a few months ago. He's now 7 years from having this implant, although you see a little hypovascularity to his lip, and if you run your finger over it, yeah, it's a little thicker, a mild fibrosis compared to the upper. But in terms of his speech, his swallow, the cosmetic, the maintaining of the oral aperture, he feels that he's normal, essentially baseline. So it's a very nice technique for precision delivery of dose only where you want it to go. Other techniques that are a little bit of yesteryear, but still occasionally very valuable. This is intraoral cone treatment, where a cone is mounted directly to the gantry of the linear accelerator to visualize through a periscope the positioning in the mouth. This is a patient of mine with an unusual presentation of non-Hodgkin's lymphoma with a pea-sized lesion in the tip of the tongue. No other disease anywhere in the body. Elderly woman, not amenable based on comorbidities to multi-agent chemotherapy. So I treated her with intraoral cone therapy. It is very easy to eradicate. Lymphoma is highly sensitive to radiation and, of course, to chemotherapy. Treated this in a 10-day schedule. Here she is a month after treatment. She lived 4 years without any manifestations of her lymphoma, without having to treat through and through all these normal tissues as might have been done with external beam techniques. And finally, the last technology I want to mention before moving to the biology side is something called MRI-Guided Radiotherapy. This is a fascinating new technology. I meant to ask Jonathan or someone, is there MRI-guided radiation here? It's where?
Coming to the Proton Center.
Coming to the Proton Center. Okay. So this is, just in the last 4 or 5 years has been emerging. And there are now three, as usual, 3 or 4 competing vendors bringing forth their products. The one that was clinically first on the scene was the ViewRay technology. We brought that in at Wisconsin at its birth time. We were the second center in the world to have it on board. And it has been fascinating because it gives you the chance to watch everything in real time while a patient is being treated. Something that the radiation oncologists will recognize is that despite all of the fancy treatment planning and field design that we do, when we actually treat the patient, the lights go off. We're not seeing the tumor or the breathing motion during treatment because everything has been CT scan based. All of radiation treatment planning, for the most part, has been based on CT scans. CT scans deliver radiation exposure, and so we don't want to leave a CT scanner on for minutes during a radiation treatment. That would really unnecessarily expose broad areas to radiation, but not true with MRI. There's no radiation exposure with MRI. You can leave the MRI on throughout the entire treatment, and it is absolutely fascinating the things that you see in doing that. So let me give you just a brief tour of this. This is, I believe, the image that is not going to work, but imagine in your mind that the MRI is just scrolling through, these transverse and coronal planes. And it's really that for a variety of tumor types, MR is a better soft tissue discriminator than CT. There are some areas, in fact, in the neck, for head and neck cancer patients, I prefer contrast-enhanced CT for neck node delineation, but certainly for nasopharynx, paranasal sinus, and for many other body sites, MR is preferable. Take this example to help demonstrate this. This is a non-contrast CT through the abdomen where we're looking for a liver lesion. You don't really see it until you give the contrast on CT. Now you're getting a sense for it. But look at the delineation of that lesion with contrast-enhanced MRI. And during the time of MRI-guided radiation, you can have this image visible while you're delivering the radiation and watch the conformal deposition, rather than on CT-based treatment planning, which has been the workhorse in radiation oncology. There's really nothing to see in the patient if you have a non-contrast MVCT that you're taking during treatment. You can't even demarcate the lesion. Same for some of the registration verifications. All of the trainees in radiation know about cone beam CTs, one of the ways to verify positioning. Cone beam CTs are notoriously modest in their precision to visualize internal anatomy. Here's the 0.35 Tesla MRI with the MRI guided, enabling us to see the liver, the kidney, the discrimination of the soft tissue. With air interference, it's very hard on a cone beam CT sometimes to gather high precision anatomic information. So here is the rendering of the ViewRay MRI guided unit. It's a 0.35 Tesla MRI scanner. It rotates. The original version, the prototype version that we've worked with over the last 4 years, has 3 high energy cobalt sources that rotate in IMRT fashion, enabling you to sculpt IMRT design. There's now a second generation ViewRay scanner that is linear accelerator based. I'll show an image of that in a moment. And this is the unit that has now commercially brought probably 8 or 10 centers in the world, and now there are about 50 that are bringing on the LINAC-based version. So if by chance this one will play, let me just see if I can get this one to go. This is a patient with a metastatic colorectal cancer, and you can generate with the ViewRay system the classic conformal design that you wish for isodoses. But then when you deliver the treatment, you can actually watch as treatment is being delivered. Let's see if I can get this guy to go. Okay, so now you can see the patient breathing, and we will coach the patient beforehand and during treatment to say, okay, now breathe naturally. Now You're doing very well. Now just let out a little bit more breath. Let out just a little bit. Perfect. Hold that. Beam goes on as soon as it's within the demarcation required. And the moment that they breathe and this leaves the fiducial demarcation, the machine goes off. So radiation is only delivered at the time where the target is perfectly positioned. And how do we know that? Because we are watching it in real time. And not only are we seeing, the big motion areas in lung and liver, but a lot of other body parts that you wouldn't necessarily think were moving so much are moving and undulating during treatment. And this has been beautifully uncovered when we're watching this in real time with the MRI. One other example where we can use on-the-fly adaptation of beam. This is a patient with a gastric lymphoma where we want to use moderate dose radiation to cover the entire stomach. Here's the position of the stomach at the time of simulation. So you think of CT simulating a patient, get a CT scan, find the anatomy of the stomach. You folks in your training do the beautiful demarcation, pass it to designate your volumes, pass it to dosimetry, create a plan. Well, that plan's going to work beautifully if the patient's stomach is the exact same shape every day. You have scrambled eggs for breakfast one day, you have a burrito at lunch the next day. Your stomach is doing somersaults. Here's the stomach on a different day of treatment. We would miss probably 40% of the stomach volume if we were using the original plan. When you design a beautiful plan and then you say, I want to give 15 or 35 treatments, do you know that that organ is in the same position every day? If you're talking about stomach, I can assure you that it is not. So here's the stomach on day 9 of treatment, completely different position. And again, we would miss probably 40% of the gastric lymphoma, which would be enough on a few days to diminish the likelihood of controlling that tumor. And so on the fly with the ViewRay system, we can adapt within a process of about 4 or 5 minutes on the treatment table from this original positioning to the new positioning and create a new plan and accurately hit that target and visualize that we are hitting it on that specific day. So this is personalizing cancer treatment for that patient, for their stomach on that day of treatment. So much better than a generic, I'm going to give 15 treatments to the stomach, who knows where it really is day to day. And this is the linear accelerator-based MRI from ViewRay. That is, we're just finishing the installation of this in our clinic to replace the prototype version. And there are, as I mentioned, many of these going in around the world. There are other competitors. Elekta has produced a beautiful MRI-guided radiotherapy system. These are going to be increasing rapidly over the next several years worldwide. So now I'd like to move to the biology side. You've seen plenty already this morning on the technical and the physical side of personalizing treatment. But there's a lot of fascinating things happening on the biology side. This is an old cartoon of molecular targets in different classes, and there are hundreds and hundreds of molecular agents that have been developed specific to aberrancies of tumor cells and tumor milieu. Although agents in all of these categories have emerged, to date still the most mature in terms of phase 3 trials comes out of category 1, the growth factor receptor inhibitors, HER family, VEGF family. Here where we have many approved agents for a variety of solid tumors. In my own experience, I've had a long interest in the epidermal growth factor signaling pathway dating back over 20 years. And this cartoon illustration was at a time where the monoclonal antibodies to the EGFR and the early tyrosine kinase inhibitors to the EGFR were just being developed. And my laboratory and others were looking at the impact of inhibiting EGFR signaling on radiation and drug response based on the known mechanisms of action of EGFR agents. One of the early studies in my lab that was so interesting to our group and other laboratories around the world were looking at what at that time was called C225, now known as cetuximab. These are head and neck tumor xenografts, human tumor squamous cell carcinomas growing in athymic mice. Here, control growth where tumors grow rapidly. The delivery of modest dose radiation or cetuximab can induce a growth delay, 2 to 3 week growth delay, but then you recapitulate the same slope of growth after several weeks. Whereas if you combine those identical doses and concentrations together, you eradicate the majority of the tumors and see no further growth. This was a very striking finding. Certainly in our laboratory, we were not anticipating this. In vitro, we had seen modest impact of EGFR inhibitors, but in situ and animal model systems, it was much more powerful. Our group and many others identified a variety of the underlying mechanistic aspects of how EGFR inhibition might complement radiation, even as simple as the fact that EGFR inhibition induces a G1 cell cycle arrest. Radiation is a known G2 arrestor. Very difficult for a tumor cell to overcome dual attack at different cell cycle checkpoints. Other aspects noted here. This led to an international trial that was carried out in this time frame, a very simple trial. Patients treated with curative intent for advanced head and neck cancer with either radiation or radiation plus cetuximab. The beauty of this timing is that in 1996, 97, 98, as this trial was designed, radiation alone was a standard of care for non-operated head and neck cancer patients. This was just prior to the era of concurrent chemoradiation. It wasn't known in 1998 that you could augment outcome with concurrent chemotherapy. That didn't emerge until about 2000, 2001 when the first meta-analysis from Europe came out. So fortuitous that this was such a simple design. And this paper following this study was published in 2006. There are authors in this room, Dong Xin from this group who participated in this landmark study, and maybe others from the group. And the mature follow-up at 5 years maintained a 10% overall survival advantage for patients who received the combination of radiation with cetuximab over radiation alone. So this was a very powerful finding in head and neck cancer and in oncology more broadly. This was the first phase 3 trial to demonstrate a survival advantage using a molecular agent combined with radiation. Toxicity was modest. The compliance was very high for this regimen. And yet, you would think, well, this would just be the opening of so many other opportunities. Now, because the era, 1998 to 2002, was when the MOC-NC meta-analysis showed that concurrent platinum delivered with radiation could further augment outcome. The next logical trial was to say, well, let's take chemoradiation with radiation and platinum and study that head-to-head against just adding cetuximab to chemoradiation. At that time, there was groundswell of belief that this would be just like the prior trial, showing an advantage of adding the molecular agent. 1,000 patients were accrued to this RTOG trial in record time, looking at this question. When the study was evaluated, again fairly rapidly, within 2 years of completion, there was not only no impact on progression-free survival, no impact on overall survival, but in fact, the toxicity profile was considerably higher for the patients that had the triple therapy than the double therapy. So then, as I'll make a joke about in a moment, then all sorts of people wrote reports and editorials about why this didn't work. None of those voices were really there before the trial was done. It's really remarkable how common we like to comment on why things work and don't work after they're done, but there aren't as many of those voices before trials are carried out. So what is the challenge? Well, part of the challenge is that any molecular signaling pathway is a lot more complex than a single molecule or a single linear pathway. This cartoon of the ERB family or the HER family just begins to tell this story. We've been talking about EGFR, which has the name HER or HER1 or ERB1. This is only one member of a family of 4 dominant receptors. We know the HER2/neu receptor is very critical in breast cancer. In 1998, we knew almost nothing about HER3 and HER4. Now there's a lot more known about these family members, particularly HER3. And the interaction of these family members in signaling has also been beautifully unraveled to a much better degree over the years. In this illustration, published in, again, 16, 17 years ago by Yossi Yarden and Mark Slakowski, this was one of the early descriptions of the complexity of the horizontal network of molecular signaling for the HER family. The fact that when ligand binds to a HER receptor, it induces dimerization. And you have the marriage of either a homodimer or a heterodimer with, whether it be HER1 with HER2, HER2 with HER3. And depending on which combination, that dictates the nature of the downstream signaling and the ultimate physiologic and cell survival effects. So far more complex and intricate than just a linear signaling pathway, as with virtually any molecular signaling pathway. So that led in the mid-2000s to the development of some very interesting next-generation EGFR inhibitors. One of them from Genentech is MEHD 7945A. And the reason for the development of this antibody was the finding that when you suppressed EGFR with cetuximab or other EGFR selective inhibitors, over time we would see the compensatory increase in HER3. So ERB3, dramatic upregulation when you're continually down pressuring EGFR. So Genentech developed an antibody monoclonal that had binding capacity for both HER1 and HER3 on each of the FAB fragment arms. This is really a genius logical creation of a molecule, knowing that the biology suggested HER3 was an escape mechanism for EGFR inhibition. So both in my laboratory and a variety of others, we looked at this antibody and the capacity of HER3 to mediate not only radiation response but acquired resistance. Could this kind of a compound molecule overcome resistance to EGFR inhibition? Whoops. And so this was the period in time where many laboratories, including our own, were generating cetuximab-resistant clones by months of overexposure in culture to cetuximab. Basically, we're just dumping cetuximab on cells, killing most of them, taking the survivors, reculturing them, doubling the amount of cetuximab, killing most of them, taking the survivors. You do that for 6 months, you have got the meanest, most cetuximab-resistant cell clones you've ever seen. And so these are some examples. Here's the parent line that responds beautifully to cetuximab. Here are some of the resistant clones. They do not respond at all to cetuximab. A lot of molecular changes have occurred, and one of the dominant ones is this big upregulation of HER3. And so it seemed like we were on to such a hot topic. And we could see it in the animal models too. Here we now have control head and neck tumor in green, growing beautifully over a few months. Now we take our cetuximab-resistant clones, we grow them as xenografts in the mice. They grow just like the control. Cetuximab doesn't do anything to inhibit the growth. The MEHD, which touches the HER3 and the HER1, that has a better effect. And we could also show that even with the cetuximab resistant, not responding to cetuximab, as soon as you add MEHD, boom, you regress those tumors. So it tells you the HER3 is critical to the growth of these tumors, and you need to address both of them if you're going to successfully regress those tumors. We raised erlotinib-resistant tumors. We raised all sorts of EGFR-resistant lines. Same thing here. We're control in green, erlotinib-resistant tumor that only attacks HER1, EGFR. Now you add ME-HD, which touches HER3, and rapidly regress those tumors. So this seemed like a very beautiful method to not only, we could augment radiation response, but we could overcome or prevent resistance to the EGFR inhibitors by addressing HER3 simultaneously. And so we and others wrote a series of papers on this, and a nice clinical trial was mounted that looked at ME-HD compound in head and neck cancer called the Megan study. And suffice it to say, these were about 120 patients that had metastatic recurrent head and neck cancer, had already been through initial therapies. They got randomized to either cetuximab or the ME-HD with the hope that the ME-HD patients would do much better. Fortunately, they did exactly the same. And although the preclinical data was so powerful for the role of HER3, at least in this study, and it's only a single study, but it was a fairly deflating one to this arena, we couldn't see a benefit in that clinical cohort. I want to also acknowledge my colleagues here who produced a nice commentary on this paper, and I think very similar to the feelings that I had, that they felt, gee, there's such strong preclinical data. The laboratories here had also shown in culture model systems and in animal model systems the upregulation of HER3 and the powerful benefit of knocking down HER3. And so I think for Nabil and Dong and others here, I so much shared the disappointment in that clinical trial because I thought it was going to open this whole new window. To date, we don't have this validated in clinical trials. That single trial, be it right or wrong, it certainly looks right in that trial, although I still harbor some question as to whether this could be a viable therapy, but it hasn't been confirmed in a clinical setting. So back to the bringing forth of cetuximab with radiation in head and neck cancer. This, as I mentioned, was a landmark trial in the first trial to show molecular targeting agent combined with radiation could increase overall survival for a curative cohort of cancer patients. So this was part of the FDA registration to use cetuximab with radiation in 2006. How many agents were going to follow this cetuximab example? I will say naively that I thought dozens and dozens of agents. I thought for every solid tumor where radiation plays a dominant role in cure, that the ability to bring a molecular agent in concert with radiation that might logically show an increase in outcome was going to bring a whole series of FDA registration in this setting. So as you may or may not know, the answer to this question is 0. Not one single agent has been FDA registered in concert with radiation since the cetuximab trial. This is a huge disappointment. What are some of the reasons for that? Well, this is that Monday morning quarterback comment that I made before. One aspect is phase 1 trials were really designed for drug, and it's challenging to study drug radiation combinations in the phase 1 setting. It's a tougher road for pharmaceuticals to make, and they're a little bit afraid of it. Even though the cetuximab example is a solid one, it's easy to study new agents in the metastatic recurrent setting because you can just give that agent alone and either you get a response or you don't. In the curative setting, because half of radiation patients are treated for cure, you have to respect whatever is the standard of care. So if the standard of care is radiation and cisplatin, and you want to study a new agent with radiation, you're going to have to add that on top of the standard backbone. So that raises a lot of complexity for registration. The other challenge is that radiation itself induces a tumor response most of the time. And so if you're needing to look at is the new drug helping you, you don't have drug alone you have to have drug with radiation. It can be a challenge to discriminate which is imparting the impact. So there are some design challenges here. This is the comment I've already made about even when trials are completed, we don't always know why they fail, and frankly, we often don't even know why trials are successful. Again, the commentary and the editorials, it's a fascinating human nature thing about the explanations of why it worked or why it didn't work. They are so powerful and so confidently stated after the results are there, but those voices are seldom there prior. So my own recommendation in the radiation drug clinical arena is that yes, we need preclinical testing, but frankly, we just need more trials, more bringing of drugs in tandem with radiation, and there are more and more avenues to do that. We just had a beautiful FDA, AACR, ASTRO workshop in Bethesda last month, where the entire focus of the workshop was how to bring drug radiation trials forward more rapidly. And I think the pharmaceutical industry was well represented there. There's some beautiful paths forward there despite the challenges that I've mentioned. There's so many opportunities. Tumors where radiation plays a key treatment role. There's a chance to improve curative therapy, just like the cetuximab trial, or to enhance palliation. And in this era of new thinking about oligometastatic disease, this is another ripe arena for using radiation combined with new agents to see if we can augment the oligometastatic control. So when to study radiation combinations with drug? Personally, I feel like it just has to be done far more frequently, and there are nice examples of that beginning to move forward. How infrequent has it been? Well, this was an interesting pie chart that was created by, at that time, Zach Morris was a resident in our program. He's now a very talented junior faculty member. Zach and I just looked at a snapshot in 2014 of all phase 3 trials in oncology. These are mostly drug trials, these are radiation trials, these are molecular targeted agent trials. Look at the slice of the pie that is radiation and molecular targeted agent. It was less than 1% of phase 3 trials. So obviously we're having a problem bringing these forward and need to look at avenues to do this more effectively. I want to close by making just brief comments in the head and neck arena about HPV. This is clearly not only a head and neck issue. We've known for many years that virtually all cervix squamous cell carcinoma is HPV associated. Most of the anogenital tract cancers, a certain cohort of liver tumors around the world, and now in the last 15 years we know that a predominant subset of oropharynx head and neck cancers are HPV associated. These are fascinating tumors. They behave differently. They are a unique entity. These are not smoking and drinking related tumors. These are HPV viral associated tumors occurring here in the tonsil or in the base of tongue. Outcome results are markedly improved for these patients. Higher cure rates, diminished recurrence rates, easier to respond, more crisp response to radiation and chemotherapy. This is a study from our group, paralleled by many around the world, showing this tendency for higher radiation sensitivity in the HPV-derived tumors than the HPV-negative tumors. And we see this repeatedly. This is leading to dose de-escalation trials around the world, reducing radiation dose, reducing chemotherapy dose, in some cases to very significant proportion. There are some studies now looking at 30 gray radiation instead of 70 gray radiation. So a fascinating area, and yet we still have so much to learn about the molecular underpinning. We're now doing mostly empiric clinical trials on dose de-escalation. What is happening in the background is deciphering more of the molecular viral oncology that is going to bring new opportunities in different ways to address these tumors, not to mention vaccination. If we had uptake of vaccination worldwide of all boys and girls at age 10, 11, 12, we probably wouldn't have any of these HPV-associated head and neck cancers. And finally, I want to call your attention to an article you may or may not have seen, but I just found it so fascinating because it's in the head and neck arena. This is another biology advance looking at circulating either tumor cells or DNA, in this case looking at EBV DNA in the plasma to screen for nasopharynx cancer. Now, this is an early study. There's a lot of challenges with it, but it is fascinating. This was done in Hong Kong, and EBV DNA was measured in 20,000 asymptomatic participants. 309 of them had positive EBV DNA. Of that 309, then a flexible fiber optoscope was just put up in the nasopharynx, and 34 of them had an abnormality in the nasopharynx. And as you can imagine, the stage distribution of these early nasopharynx cancers was skewed to be a lot earlier because they were asymptomatic. Here's in the paper, the classic distribution of nasopharynx stage, where there's a lot of stage 3 and 4. Green is stage 1. You basically have this high percentage in this screened population of very early nasopharynx cancer. Here's an image of one, a tiny little T1 in the nasopharynx. Cure rates for this patient would be on the order of 90%, radiation alone. And so this screening of EBV DNA in the plasma was useful in asymptomatic patients, detected earlier, outcomes terrific. Challenge is, they had to screen 20,000 patients, and so it probably is not yet going to be cost effective, but it's opening the window as these technologies are getting cheaper and cheaper to think about in high-risk populations like in parts of Asia for nasopharynx, where in many areas it's the number one cancer in those regions, to think about finding them much earlier. And the last comment I'm not going to talk about, but just you're very well aware of the advent of immunotherapy in oncology and the fact that radiation is in a beautiful situation related to immunotherapy, because radiation is one of the most potent exposers of antigens from early treatment of a tumor, where a single dose of radiation can expose all sorts of antigens and byproducts of the tumor cell that can then turn on the immune system. And some of the effects of radiation are noted within seconds to minutes, some hours to weeks, and some days later. And there are a variety of laboratories around the world that are looking at this very carefully. And the hope is that we'll come to a point where we will be personalizing radiation dose, much as we're trying to personalize the selection of a molecule for a particular cancer patient. The early papers commenting on, in this case, genome-associated radiation dose reduction have come out just in the last year, looking at methods to individualize radiation dose based on characteristics of the tumor. This is this GUARD technique, looking at a variety of genomic elements that may relate to the ideal radiation dose prescription. This has also been recently postulated in head and neck cancer, where not only genomic information, but radiomic information, the characteristics through high throughput evaluation of images that can lead us to conclusions about dose required. We will, based on the age I'm guessing for a lot of these trainees, in your career, you will see this come to fruition, where there will be radiomic and radiogenomic analysis in large cohorts of patients. Maybe it's 8 years, 10 years, 12 years from now, that is going to guide radiation dose, rather than say all head and neck patients get 70 gray, all lung cancer patients get 60 gray. How silly is that? We should be individualizing that dose based on that individual patient's tumor. And finally, this is a paper to show that I'm keeping you really up to date. This paper hasn't even come out yet. It'll come out in May, and it describes this topic that I've spent a fair bit of time mentioning, that we're in a time frame in oncology history where combining precision radiation with more of the molecular and immunomodulatory agents is very ripe to make meaningful improvements in cure rates and palliation effectiveness in cancer. So back to our head and neck cancer patients. In the future, we'll always continue to serve the individual patients, but I think we're at a point where we're ready to marry personalized biology with high-end technology to bring the very best outcomes. Thank you on behalf of my laboratory team, and thank you on behalf of the Wisconsin Head and Neck Spore team, all of which has contributed to components of this seminar. Thank you very much.